I think most of you know what osteoporosis is, but to level set and just make sure we're on the same playing field, it's a systemic disease that's characterized by weakened and fragile bone tissue, which leads to an increased risk for fracture. That's ultimately the sequelae that we are trying to prevent. Right? A couple of key points: tends to be a silent disease until a fracture occurs. People don't know they have it. In and of itself doesn't generally have symptoms. It's extremely common, but it remains underdiagnosed and undertreated. And I'm not really going to go through a lot of the demographics and epidemiology today because I want to focus more on screening and treatment. But suffice it to say that with the aging of the population and the silver tsunami, no matter what field of medicine you go into, you are going to see patients who have osteoporosis, or the treatments you give cause osteoporosis. The key point is that fractures have serious consequences. They can be life-altering events. That's why we treat. That's why you should care. There's an increased risk of mortality. 30% of patients die in the first year following a hip fracture. So not a benign disease. It can lead to disability. And what patients care most about is remaining independent and mobile, and it can change the trajectory for both of those things. And key concept is that this is a chronic disease. Right? Just like other chronic diseases you treat in medicine, we can manage it, we can treat it effectively and reduce fracture risk, but we don't cure it, so it requires long-term management. So I put some bone density results from an axial DEXA here, just to sort of say, okay, so this woman gets screened, or perhaps she came in for another reason. I don't know if you can see from the back, but her lowest T-score is a -2.7 at the lumbar spine. That means that her bone density is 2.7 standard deviations below a group of healthy normal controls. That gives her a diagnosis of osteoporosis. So what? Do we treat based on that? What does that mean? Or is bone density just a piece of the puzzle? It's an important piece, as you can sort of see here on this slide. So this is looking at the relationship between bone mineral density and fracture risk. And frankly, it's a better surrogate marker than cholesterol is for heart disease, than blood pressure is for hypertension. So in people who have not been treated, it is very predictive. For every 1 standard deviation below that normal healthy control group that one is, you have about a 2-fold increased risk of fracture. And the lower the bone density, the greater the risk for fracture. So clearly, this is something that's important, and it's a very useful screening tool. But bone density alone doesn't tell us the whole story. This is data that comes from the NORA trial, which looked at over 200,000 women in the US who had had some form of fracture, and looked at what their bone density was and how those things correlated. So if you look at the graph, on the x-axis from left to right, we see decreasing bone density. If you look at those who have had fractures, okay, and look at fracture rates in the lighter blue columns, the lower the bone density, the higher the bars and the greater number of fractures. Makes sense based on what I just showed you. But if you look at the bone density of the greatest number of people who have fractures, shown in the dark blue bars, they fall into the low bone mass or osteopenic range because there are more people with low bone mass than with osteoporosis. And so there must be other things going on as well as low bone density that confer risk. We had to think about the 3 biggest risk factors. If you told me I could only talk about 3 risk factors for fracture, it would be the 3 that are listed here. Bone density for the reasons that are obvious, and anything, any T-score less than -2.5 sort of confers high risk. Age, this is a disease of aging, which is better than the alternative, but the older we get, the greater the risk for fracture. And we arbitrarily use age 65 as a cutoff, okay? The single most important risk factor for future fracture is having had a prior fracture. The more fractures you have, the greater the risk for fracture. The more recent the fracture, the greater the risk. There have been a number of different studies that have been done, one by Van Giel and colleagues, that showed that in the first year following a prevalent fracture, there's a 5-fold increased risk of subsequent fractures. So there aren't very many osteoporosis emergencies, right? People don't become osteoporotic overnight, But if ever there were to be an urgency or an emergency, it's in the group of people who've had a fracture because their highest risk of refracture is in the first year to 2, although it remains elevated out to 8, 10 years and beyond. And then there are a host of other risk factors. This is not all inclusive. We could spend the rest of the hour talking about risk factors, but you can see that many common diseases that we treat, I've got the rheumatology division in the front here, so certainly rheumatoid arthritis, but importantly, diabetes as well, both type 1 and type 2, increases the risk for fracture. And then there are some things we can change in terms of habits, others that are not modifiable. But the greater the number of total risk factors, the greater the risk for fracture. How many of you are familiar with fracs? Can only sort of pull the people in the room, but anybody in the back? Okay, so this, along with other tools like Garvin and Q-Fracture, are risk assessment tools that usually the output of which is either 5, or in the case of fracs, 10-year absolute risk of fracture, right? Which takes into account not only bone density, tool can also be used without bone density if you don't have a DEXA scan, and the clinical risk factors that are listed on the side that have been well validated across about 65,000 people worldwide. There's country-specific information, and the output is the 10-year risk of hip fracture and the 10-year risk of major osteoporotic fracture. The tool is meant to aid in decision-making and really meant to be used in people who have low bone mass. Somebody's got normal bone density, not much else going on and hasn't fractured. You don't really need a tool to assess risk, and you're probably going to talk about non-pharmacologic therapy. They have established osteoporosis, the same holds. But that group of people with low bone mass or osteopenia in the middle is a big group, some of whom are at high risk and should be treated, some of whom are not, and we don't want to overtreat. And so there are risk assessment tools that can help make that decision. In the US, the current recommendations are that if somebody has a 10-year hip fracture risk of 3% or greater, or major osteoporotic fracture risk of 20% or greater, that would be a trigger to consider treatment or pharmacologic intervention. And that sort of leads us to an expanded clinical diagnosis of osteoporosis. So all of our current guidelines across societies pretty much agree on this point, that we can make a diagnosis, as you see in the first bullet up top, with a T-score at any site that's measured of -2.5 or lower, and it's the lowest T-score that gives a diagnosis. People only get one diagnosis. You shouldn't see a report, which we do all the time, that says this patient has osteoporosis at the spine and osteopenia at the femoral neck and normal bone density at the wrist. I don't know what that means, right? This is a systemic disease. So it's whatever the lowest diagnosis is. So that's fine. But there are other ways to make a clinical diagnosis and find people who are at high risk. Somebody has had a hip or a spine fracture without other underlying cause, that's osteoporosis regardless of bone density. Okay, we get a bone density often. It's helpful to have a baseline. It's something to monitor, but you don't need to wait for a bone density to make a diagnosis and to treat in that scenario. If people have low bone mass, so fall into that osteopenic category by T-score, and they've had another classic osteoporotic fracture, proximal humerus, distal radius, pelvis, some of the guidelines would say sort of any other fracture, that's a clinical diagnosis of osteoporosis. And then lastly, if you have low bone mass and are above those thresholds that I mentioned before, that can give a diagnosis as well. So the paradigm is sort of shifted from solely looking at bone density to kind of looking at what's the overall risk, trying to risk stratify so we treat those who need to be treated and don't treat those who don't. And I would be neglectful if before we start to talk about medications, if I didn't at least mention this whole concept of treating the whole person, right? It is Georgetown, and talk about cura personalis. So we need to think about non-pharmacologic strategies regardless of what else one does. It also puts a little bit of that locus of control back with the patient because these are things that they can be involved in and do. We all think about calcium and vitamin D, which are some of the building blocks, and I've written the daily requirements there. Well-balanced diet overall is important. There are certain things to avoid, high salt diets. That's all probably a topic for another day. as patients get older in particular, but for all of us, ensuring adequate protein intake, because protein keeps muscles strong. And if you have weak muscles or sarcopenia, and you fall on weakened bones with osteopenia or osteoporosis, that combination leads to fracture. And that's sort of this syndrome of frailty. And then up top, exercise is important, but it's not just aerobic exercise. It's a combination of aerobic exercise, strength and resistance training to stimulate bone remodeling, and importantly, balance training as well to prevent falls. Okay, so with all of that as background, let's move into osteoporosis treatments that are available in 2024, because we have a number of treatments that effectively reduce fracture risk in patients with osteoporosis. And they really fall under two major umbrellas. And I know you're probably aware of this, and for anybody who was a student here, you sort of heard me do this in the pharmacology course, but we'll delve a little bit more deeply into it now. So we have our anti-resorptive agents, right? Those are medications that inhibit bone resorption and to a lesser degree also inhibit bone formation, because generally those processes are coupled. What falls into that category are hormones. So estrogen, whether alone, in combination with a progestogen, or with an estrogen agonist antagonist, specifically beta-doxyphene. Raloxifene, which is an estrogen agonist antagonist. And both of those classes of medications have a role. We're not really going to spend too much time talking about them today. Happy to talk about them at the end if there's time and there are questions. What have often been our mainstay of therapy in terms of anti-resorptive drugs are the bisphosphonates, whether in oral form or intravenous drugs, and denosumab, which is a rank ligand inhibitor. The other umbrella of medications are what we call our osteoanabolic agents, and they work primarily to stimulate bone formation. There are two sort of subgroups under that. We have what we call remodeling stimulators because they increase bone formation primarily, but they also, to a lesser degree, increase bone resorption. And that's where we find the parathyroid hormone analogs, so teriparatide as well as abaloparatide. And the newest of the agents, which is a modeling stimulator, which is the one dual action agent we have, meaning that it increases bone formation and decreases bone resorption. So it kind of works on both sides of the equation, if you will. And that's romosozumab, which is a sclerostin inhibitor. And we will talk about some of the medications and nuances with each. Again, I know I mentioned this earlier, but really important because patients don't often focus on this, and not all clinicians do either, right? One of the first questions that I get from patients, if I can get them to agree to take something, is, how long do I have to be on this? Well, specific agent, I don't know, we'll talk about it, but you're going to need to be managed for the rest of your life because osteoporosis is a chronic disease and progressive over a long postmenopausal lifespan for women and over a long aging lifespan for men. As I mentioned earlier, it can be treated effectively and fracture risk can be reduced, but there's no cure. So we have to think about long-term management. The need for medication and the agent that we choose should be individualized. Nothing is forever, right? And medication should change over time based on somebody's increasing age, change in disease severity, how they've responded to something we treated them with, other concomitant underlying medical conditions or illnesses or medications. You could certainly add to that list. So these are some of the key topics or groupings that we think about when we try to help determine, what do I pick out of that armamentarium I showed you? How do I decide what agent I'm going to start with? And the first of the topics that helps to inform this is risk stratification. So if you take nothing else away from this talk, well, hopefully you'll take a number of things. But the state of the art in 2024 is really to assess baseline risk for fracture and use that to help guide what agents one starts with. I know it's a busy slide. It's sort of a compilation of all of the guidelines that I have listed at the bottom. And I'm happy if people want a PDF version or if you guys want to post a PDF version of this so everybody can see it, that is fine. But we really divide people into low risk, moderate risk, high risk, and very high risk. We're going to focus for most of the remainder of the talk on high risk and very high risk, but a couple of quick words about the low risk group. So who might be low risk? Patient who's not had a prior fracture, who either has low normal or maybe even mild low bone mass or osteopenia, not really any other risk factors, and low fracture probabilities. But you want to do something, or they want to do something to prevent loss and becoming osteoporotic, because we know, particularly in women following menopause, actually bone loss starts during the perimenopause and menopausal transition, that if we do nothing, most women are going to lose bone and will become osteoporotic at a much earlier age than somebody who doesn't lose bone. We don't allow that to happen. So non-pharmacologic strategies, and for those who are candidates, sometimes talking about estrogen for prevention can be appropriate. Sometimes we also use intermittent bisphosphonate dosing, protect them for a while, give them a little bit of a break, protect them again to prevent that loss. Moderate risk, you can imagine, no prior fracture, bone density in the low bone mass range, or maybe close to the osteoporosis border, but primarily at the spine perhaps, and elevated fracture risk, but not above those thresholds. This is where, again, the thought of estrogen perhaps, raloxifene, although it only protects at the spine from a fracture prevention standpoint, or the use of bisphosphonates now may come into play. But let's look at the other two groups, and I'm going to start on the far right with the very high risk group category. Anybody we're really going to treat with some of the agents that we'll talk about, if you think about it from that perspective, are going to be at high risk for fracture. But the guidelines now differentiate high risk from very high risk. I'm not sure it's the nomenclature I would have used, but it is what it is. That's what they sort of gave us. That very high risk group has what we call a high imminent risk of fracture. As I mentioned before, somebody who's had a prior fracture, we worry about another fracture in the short term. And so this group is an older patient who's had perhaps a recent fracture or maybe more remote multiple fractures. If you're looking at bone density alone, this would be the person who has a T-score less than -3, or the Endocrine Society would say less than -3.5. Those are pretty low scores. And or fracture probabilities over the next 10 years, not 3% or 20%, but 4.5% or greater than 30% at hip and major osteoporotic fracture. So this is a group where we really want to do something that's going to work quickly, that's going to build new, stronger bone, and that's going to rapidly reduce fracture risk. And this is where our first-line treatment should really be the use of an osteoanabolic agent, unless otherwise contraindicated. Okay, in some cases, if that's not tolerated, we may start with a bisphosphonate or denosumab, but we're really focusing on our anabolic agents. And then because we generally use them for a limited time, when that course is completed, we would then transition to a potent anti-resorptive. In the high-risk group, so still at high risk for fracture, maybe a more remote fracture, a single fracture, bone density that's not quite so low, this is where often first-line therapy would be a bisphosphonate or denosumab. Anabolics may be appropriate. And if you think about the way anabolics work, we'll talk about this more in a moment, physiologically, if I could, I'd give everybody an anabolic, because conceptually, why wouldn't you want to build more strong bone and repair the underlying microarchitecture as opposed to maintain bone where it is? But because of nuances and expense and all kinds of other caveats, and utilization of resources, that's not the way we do it. But conceptually, makes a lot of sense to use an anabolic. The second piece of information that helps to inform our decision, or why we sort of think about osteoanabolics now being first line, is we have comparative fracture data showing that our anabolics are more effective in reducing fractures than some of our anti-resorptives. There are additional studies, but I've called out two of the studies here. The Vero trial, which compared teriparatide, a parathyroid hormone analog, to risidronate, and showed in high-risk women with osteoporosis and one or more vertebral fractures that there were fewer vertebral fractures in the teriparatide group at 12 months. And then I will show you some data afterwards from the ARCH trial, which compared romosozumab head-to-head with alendronate in over 4,000 women, again, all of whom had had a fracture, and showed fewer vertebral fractures, non-vertebral fractures, and hip fractures in the romosozumab group. So when we have randomized controlled trials that give us good data showing superiority of one group of medications, that helps to inform. There's all, yeah.
Would all those people fit into, in the prior slide, into the very high risk? Because they've had fracture and they have bad PMP.
Yeah, so most of them would have, they didn't all necessarily had to have had a fracture within the prior year. So there may have been some who are on the border based on timing of that fracture, but they all had to have osteoporosis by T-score less than -2.5. They all had to have at least one fracture. These were women, depending on which study we're looking at, average age at entry 71, 74, so they were older people, so yes. So I think we're making the argument that those types of patients indeed are high risk and would benefit from osteoanabolic agents. Yeah. There is some comparative effectiveness research that's been done that actually compares denosumab to alendronate individually, all three oral bisphosphonates combined, and IV zoledronic acid, which showed that regardless of which group we were comparing to, denosumab reduced the risk of hip fractures and major osteoporotic fractures more effectively. Now, these were not randomized controlled trials. This is looking at a large database of people 65 years of age or older, Medicare population database. The advantage is you have hundreds of thousands of people, so you have a lot of data to pull from. The disadvantage is you can't control for all of the things that one can control for when you're recruiting for a randomized controlled trial. But again, it adds to sort of the body of literature and evidence. The next thing really has to do with treatment sequence. The idea of waiting, of using an anti-resorptive first, waiting till somebody fails it, either has a fracture while they're on it, loses bone density, isn't improving, which is what has traditionally been done with sort of what I would call step therapy, is probably not the most efficient use of our osteoporosis medicines. And that's because if we treat with an anti-resorptive first and follow it with an anabolic, that can cause either a delay or an attenuation of the effect of the anabolic, or in certain circumstances, shown in the upper left-hand corner of the slide, if you go from denosumab to teriparatide, you actually can have a transient loss of hip bone density. So cortical sites, bone density can actually decrease. So not only are you not helping the person, you may actually temporarily do some harm. And what the data shows on the right, whether we're looking at teriparatide, that's the TPTD, or romosozumab, if they're used de novo in treatment-naive patients, we get better bone density builds, whether at the lumbar spine on the left or total hip on the right, as compared to a somewhat blunted response if it follows a bisphosphonate and a more blunted response if it follows denosumab. Okay, so the idea that there is a preferred sequence matters. And the last concept that I want to introduce is something called goal-directed therapy, or treat to target. Most diseases that you treat, you have a goal in mind, right? If you're treating somebody's blood pressure, you're going to get them to a target blood pressure. And if not, you're going to change medications or adjust doses or combine, do what you need to normalize their blood pressure. The same usually with lipids, although we could argue with the most recent ATP3 guidelines, we're basing it on risk, but we still look at LDL and try to sometimes aim for a target, especially in high-risk groups. Or maybe diabetes is a better example, where we're treating toward an A1C. We've never really done that with osteoporosis. And it's difficult to sort of get people to get their heads around treating to a non-event, right? Not having a fracture. A lot of the literature would suggest that we ought to be treating to a target. There's been some argument, if you will, in the field about what's the right target. First of which is certainly keeping people fracture-free, but the second of which may be a bone density goal. And if -2.5 as bone density is what triggers us to treat, then our goal ought to be to get people at least better than -2.5, and in many respects, better than -2. It also then speaks to the fact that if you are aiming for a goal, if you have a T-score of -3.9, an oral bisphosphonate is not going to get you to a T-score better than -2.5. So you might think about choosing an agent that has a greater likelihood to improve bone density, as well as reduce fracture risk. And there is a lot of data. I'm only showing you a couple of slides from the FNIH or SABRE database, which looked at all of the osteoporosis drugs we have, including some that were not approved, but for which we have fracture data that essentially show that the better the on-treatment bone density, here we're specifically looking at bone density at the hip, the lower the fracture risk. So vertebral fractures are shown in the top slide, hip fracture rates shown in the bottom. But the more we improve bone density, and that's true whether it's spine, hip, or femoral neck, total hip bone density is the most reproducible to follow, the better the outcomes in terms of fracture reduction. So it's more than just a concept. We have significant data to sort of back that up. So I want to talk specifically about some of the agents that we have and maybe some of what's new or some of the nuances that we need to consider. And let's start with the bisphosphonates and denosumab because they're what we use very commonly. And even if we don't start with them, they are often what ends up being sort of long-term maintenance therapy after whatever our initial therapy was. They offer effective protection from fractures. There is rapid reduction in fracture risk within just 12 months. They continue to work with long-term use. In general, they're well tolerated, and they have a favorable safety profile, and used in the right patient, benefits outweigh the risks. You can see fracture reduction rates shown here. This is not meant to directly compare zoledronate and denosumab because there aren't head-to-head trials. They're head-to-head bone density trials, not fracture trials. But with our anti-resorptives, we get about a 70% reduction in spine fracture, 40-ish% reduction in hip fractures, and non-vertebral fracture risk reduction in the 20 to 25% range. What about using these drugs long-term? Well, some differences between bisphosphonates and denosumab, and some of that is shown in the top slide. So with bisphosphonates, you tend to get an increase in bone density over the first 3 to 5 years, and then as you can see in the yellow line at the top, it tends to plateau. You'll continue to maintain whatever goal you've reached, but it's not going to continue to go up exponentially. So if you're not at your target, you might have to think about something different. That's not the case with denosumab, where the long-term trials out to 10 years show continued increases in bone mineral density builds. Same when we look at fracture risk reduction. With zoledronate or bisphosphonate therapy, we're looking at on the left, you get a lowering of fracture risk after about 3 to 5 years of therapy. That risk stays low, but it doesn't continue to go lower. Whereas with denosumab, there's some ongoing continued reduction in fracture risk over the longer term. So when we think about bisphosphonates, keep in mind, they have a very long half-life, right? Or what we call a long skeletal retention, kind of like the gift that keeps on giving, if you will. So even if somebody misses doses or you stop therapy for a time, they continue to work. Now, the effects will eventually wane, but that offset is going to be slow. And so if we're thinking about balancing the effects we get and potential rare events, long-term complications, side effects, that's where this whole concept of a potential drug holiday came in to play. If you have improved bone density, somebody's been fracture-free after 3 to 5 years, and they are now at lower risk, you might think about a holiday. 2 things. Holidays only apply to bisphosphonates. There is no other osteoporosis drug for which we can use a direct holiday. Second of all, holiday doesn't mean drug retirement. It means a temporary cessation of treatment because all drugs stop working eventually. So if you do give a holiday, you still need to continue to monitor people, and eventually they'll need to restart treatment. I can't tell you the number of people that I see who somebody told them, well, you had your 5 years of bisphosphonate. There's nowhere that it's written that it's a lifetime maximum, right? And then sent them off, and now it's 12 years later, they've not been treated, and they come back to me with the same or worse bone density than where they started, because eventually all drugs stop working. With denosumab, we do have long-term data from a 7-year extension trial that was added on prospectively to the first 3 years of the pivotal fracture trial. And so I'm showing you bone mineral density builds at the graph at the bottom left, fracture rates at the graphs on the right side. And what you can see from the bone mineral density builds is at the end of 10 years, there was about a 21.7% increase in spine bone density in the group that started on denosumab and continued for up to 10 years, 9.2% increase in hip bone density. Fracture rates, which were lowered initially, were a little bit lower throughout the remainder of the study, so that we have not only long-term safety and tolerability data, which was the primary endpoint of this study. There was no increasing incidence of duration-dependent adverse events like osteonecrosis of the jaw or typical femoral fractures that was seen, and it appears as though bone has continued to be built and fracture reduction remains low, so there is data to support longer-term use. There's a new boxed warning in the label for denosumab I wanted to make sure people were aware of. It doesn't really change what I think had been standard practice, which was making sure that calcium levels were normal before we administer the drug, because pre-existing hypocalcemia needs to be corrected before you give any antiresorptive, really, because there's the potential to drop it lower, but more so with denosumab because it's such a potent antiresorptive. The call out here specifically in people who have severe renal disease or are on dialysis, because they are more apt to have disorders of mineral metabolism and hypocalcemia. And there have been cases of hospitalization and death following administration where that wasn't corrected. Almost all of them were in dialysis patient, but it behooves us to be very careful in anybody who might be at risk. Couple of concerns or things to know about denosumab. I'm not sure the concerns. This speaks to the mechanism of action. The point being that when you finish at the end of the dosing interval, which is every 6 months for denosumab, there's no active drug left in the body, so it can't continue to work. So if you give denosumab, and look here sort of at month 24 on the left-hand side under CTX, which is a marker of bone resorption, CTX has been suppressed sort of at the bottom. If you stop giving the drug, you're going to get a rapid increase in bone turnover because there's nothing there to suppress it any longer, which will actually overshoot where it started before it comes back down to baseline. What that is associated with is a decrease in bone density back to baseline over 12 to 24 months at most, and then kind of remaining at baseline. So you can't just stop denosumab. You have to transition to something else if you're going to. What was seen in the post-marketing era is that if you stopped it abruptly after somebody had been on it for a bit and did nothing to follow, there was an increased incidence of multiple vertebral fractures, particularly in people who had had a history of vertebral fractures, seen as early as 7 months after the last dose, but on average 19 months. So you have to do something. You can continue it, or you have to switch to generally another potent antiresorptive like a bisphosphonate or zoledronate. And this is just from a study that looked at, does it matter how long somebody's been on denosumab? And the answer is probably yes. So in this study, Felicia Cosman and colleagues broke treatment duration to under 3 years or 3 years or over. And it wasn't just single vertebral fractures that differed from the placebo group. It was multiple vertebral fractures, and it was in the group who'd been on denosumab for a longer period of time. Okay, so you have to be thoughtful if you're going to use denosumab. It's an excellent drug, but you have to have a plan going forward to think about, well, what would I do? For how long do I want to use it? Is this something that I might use forever? What might that look like? And you have to have those discussions with patients, and they have to understand that they need to stay on therapy and not just stop it abruptly without discussing it with you. With that said, there's no time limit for denosumab, so it's not as though you have to stop it at any given point. This may be getting in the weeds a little bit, but I think it's important just to let you know that there's a reference out there. How you transition off denosumab, particularly if somebody's been on it for longer than 2.5 to 3 years, is a little bit controversial. It often takes a little bit more bisphosphonate given a little bit more frequently, particularly if you're using IV zoledronate, than if you were, normally just switching and going to give standard once a year dosing or less frequently. And that's because denosumab is such a potent antiresorptive that when you stop it, you may need more than one dose to kind of suppress that rebound. So, happy to give advice or have you call or whatever if you need help. There are ways to sort of do it. And there's lots of ongoing research trying to help guide these transitions, hopefully coming down the pike. So there are roles for bisphosphonates and denosumab. We've talked about initial treatment for moderate to high risk osteoporosis. Bisphosphonates might be the last treatment of an anabolic treatment sequence to maintain benefits over the long haul. Drugs of choice after denosumab cessation. And again, you might be able to use these for long-term maintenance with intermittent dosing, which is probably beyond the scope of today's lecture, but if we have time, I'm happy to answer questions about that. Denosumab, we tend to see better bone density builds and lower fracture risk as compared to bisphosphonates. So if you have somebody who's higher risk, either has already had an osteoanabolic or is not a candidate for one, that may be where we start with denosumab, again, in a sequence after anabolic agents, and then long-term maintenance of bone density. So for the last part of the talk, let's shift to our osteoanabolic agents, because this is, I think, in large part what can be very exciting. They really address an overlooked essential pathologic element in osteoporosis that's not addressed by the antiresorptives, namely deteriorated microarchitecture. Right? Doesn't take a trained eye to look at the difference between normal and osteoporotic bone on the left. These are CT micrographs, and realize that I'd rather have the strong bone. I could see why somebody with the bone on the left is more likely to fracture. I don't think I did that. Because of deteriorated microarchitecture. With our osteoanabolic therapy, you can see that with treatment, we can move people back toward, we can repair that underlying microarchitecture and move them back toward normal bone. It's a combination of bone density and bone quality that lead to bone strength. So this is just giving you some ideas of what this looks like. The paired biopsies from the teriparatide trial show the difference between baseline and treatment in the same patient. On the bottom are biopsies from the romosozumab trial. They're not paired, but they took the average for the placebo group and the average for the treated group to show the difference. And then if we look at trabecular bone score, which is a sort of computational pixelated image that we use to give an indirect measure of microarchitecture, you can see that there are increases and improvements in trabecular bone score with teriparatide in the green on the left, romosozumab in the blue on the right, as compared to alendronate on both graphs. So the parathyroid hormone analogs bind to cell surface PTH receptors. They decrease programmed cell death of osteoblasts, and they stimulate differentiation of bone lining cells to pre-osteoblasts and then to mature osteoblasts. So there's a net increase in the number, in their activity, and we get new bone formation both through remodeling and some modeling-based bone formation. They are indicated, both of them now, for postmenopausal women and men. Teriparatide is also indicated for women and men with glucocorticoid-induced osteoporosis. They're daily subcutaneous injections that a patient gives themselves at home. Easy to do, but patients sometimes get a little squeamish. And then obviously when those drugs are no longer being used, which is often about 2 years because we get our maximal sort of anabolic effect during that time period, there's no longer a time limit for use of teriparatide. There's still in the label is a suggestion of a 2-year limit for abaloparatide. And that has to do with a prior boxed warning that spoke to an increased incidence of osteosarcoma in rats. We've not seen that in humans. Teriparatide has been on the market now for over 23 years. So that boxed warning was removed and considerations were moved to the warnings and precautions section. If you have somebody who is at high risk for osteosarcoma or bone cancer, then we generally would not use it in that setting. And I've listed some of the contraindications there. Also need to be cautious. Kidney stones, hypercalciuria can also cause some transient orthostatic hypotension. But you see significant increases in bone mineral density, about 10% at the spine at the end of a year and a half, 3 to 4% at the hip at the end of a year and a half. and reduced non-vertebral fracture risk as well. This again just sort of speaks to those increases in total hip bone density on the left, femoral neck in the middle, lumbar spine in the right, in both of those drugs as compared to placebo, and in medication compared to an active comparator, alendronate on the bottom left. So I want to move to romosozumab now, which is the newest kid on the block, although it's now been approved since 2019, so can't use the word new anymore. And it's interesting, I think, just as a little sort of history in terms of how this drug was discovered. It's sort of an experiment of nature, if you will. So what I need to start by telling you is that sclerostin is an osteocyte-derived natural inhibitor of bone formation, okay? There's a group of patients in South Africa who have a disease called sclerosteosis. It's a genetic inherited disorder where they don't make sclerostin. So because they don't have the inhibitor of bone formation, they make a lot of extra bone. And when they're homozygous, their skulls look like the picture on the right. And you can see that bony overgrowth, which from a fracture standpoint is good because they don't break things. But you could imagine there are other complications, sort of compressing narrow neural foramina, their cranial neuropathies. There are other things that cause their lifespan to be shortened. However, in their heterozygous counterparts, they have more bone than a normal control, but they don't have all of the complications that we see in the homozygotes, and they're still fracture resistant. And so that was the whole idea. If you could make a monoclonal antibody to sclerostin and get rid of some of it or block some of its activity, maybe we could reduce fractures and build bone, and that's exactly what happens. There are 3 major pivotal fracture trials. 2 fracture trials, and then Structure was a bone mineral density trial across about 12,000 women. The ARCH trial compared head-to-head romosozumab with alendronate, and I'll show you that data in a moment. The FRAME trial was the placebo-controlled trial, and then Structure was actually a transitioning trial for people who'd previously been on an oral bisphosphonate. You know, sometimes you have patients who come in and have been treated, and the question is, do these drugs work? So in that study, patients were then randomized to either romosozumab or teriparatide, and the outcomes were looking at hip bone mineral density. Bottom line is there was significant fracture reduction in ARCH and FRAME, whether comparing to an active drug, alendronate, or to placebo. This is looking at the ARCH trial. So treatment with romosozumab is just for a year. And then in this trial, both groups were then transitioned to or continued on alendronate. But you can see at the end of 24 months, statistically significant, about a 50% reduction in new vertebral fractures in the original romosozumab group as compared to the original alendronate group. At the time of the primary analysis, which was at 33 months, significant reductions in clinical fractures, non-vertebral fractures, and hip fractures in the romosozumab group as compared to the alendronate group. Bone mineral density builds from the ARCH trial on the left and the FRAME trial on the right show about a 13% increase in spine bone density at 12 months, which then continues on with either follow-on alendronate or on the right-hand side of the slide, follow-on denosumab, where you get even bigger builds, and about a 6% increase in hip bone density at the end of just 12 months. So you can see in somebody who's very high risk, that might be somewhere you want to go. The one caveat here is there's a boxed warning that speaks to the potential risk of myocardial infarction, stroke, and cardiovascular death, or MACE events, major adverse cardiovascular events, which were imbalanced in ARCH, 1.1% absolute rate in the alendronate arm, 2% in the romosozumab arm. There was no difference in FRAME. When you pool all of the data, there's no difference. But because of that imbalance, what's in the label is that if you have somebody who's had a heart attack or stroke in the prior year, you shouldn't use the drug. And obviously in all other patients, we have to balance cardiovascular risk factors with, never forget to balance it with the risk of the underlying osteoporosis and risk for fracture, right? And then make treatment decisions. Okay, so osteoanabolics appropriate for high and very high risk patients in need of skeletal rescue because of those large and rapid increases and rapid reduction in fracture risk, generally to be followed by a bisphosphonate or denosumab. Last key message, treated osteoporosis is still osteoporosis. If you have somebody who has hypertension and they're on an ACE inhibitor and their blood pressure is now normal, do they still have hypertension? Yeah, right. So somebody who has osteoporosis, you've treated them and their bone density is now in the osteopenic range. Do they still have osteoporosis? We shouldn't change the diagnosis. We can say that their bone density now meets World Health Organization criteria for low bone mass or osteopenia, but they still have osteoporosis. That helps drive home the fact that they're still at risk, albeit risk may be lower, and they still need ongoing management. So I'll just leave you with this. You can read it, sort of a summary of what you might tell patients, right? All approved osteoporosis drugs increase bone density and reduce fracture risk. Only anabolic drugs build new bone and improve structure. Any treatment is better than no treatment. I'd rather have somebody on something than on nothing. But when fracture risk is very high, it's better to begin with an anabolic drug. Anabolic therapy followed by anti-resorptive therapy is necessary to consolidate and enhance the benefits that are there. This is a lifelong disease, and all drugs stop working when stopped.